So while healthy individuals can defend their DNA against this ongoing attack on the DNA, AT patients cannot do it very efficiently, and that's the reason of their disease. So how are we using now this insight, this information about what ATM does to try to, as we say, go back to the patient bedside and help the patients? And you will hear about several different approaches to find drug therapy or other means of therapy or treatment modalities for AT, which again shows you, and that's very good, that people approach the problem from various angles, various approaches. So let me tell you briefly about our approach. And it's not something that we invented, we're just using an idea that is being used extensively by many other laboratories in the search of drug therapy for other diseases. And the idea is the following. Suppose we're not trying to make or synthesize a specific drug which is designed chemically based on what we know about the molecular basis of the disease. We can't do this, but what we can do, since there are these huge collection of small molecules, drugs that are made by companies, and are sitting on the shelves, hundreds of thousands of compounds that are made, that are synthesized almost arbitrarily, a whole variety of them. And the idea is that perhaps among those collections, there might be a few that could be useful to treat AT patients. So the collections are already there. What we need to do is to screen them in a very efficient manner, which we call high throughput screen, to identify potential drugs for a particular disease, in this case, AT, of course. So we need to design, this is of course done by big laboratories, and it's done by robots. So we are collaborating with a laboratory called Chemical Genomics Center, which is at the National Institutes of Health of the United States near Washington, D.C., because they have the infrastructure to do it. But we designed the assay. You need an assay, a readout. How will you screen those drugs in a way that actually reflects what we think about the molecular basis of the disease? And remember, we think that basically what we want to have is a drug that will allow AT cells to respond to the type of DNA lesion to which they normally cannot respond. A drug, a small molecule, that will somehow help them or compensate for the loss of ATM. And we know that if we find a small molecule that would allow AT cells to do that, not necessarily to the same extent like normal cells from healthy individuals. We know, and we have very good reasons to believe, that if we can give them back the ability to respond to those specific DNA lesions at a rate or extent which is maybe only 15 or 20% of the normal, the ability of a normal cell, that will make a huge difference for AT patients. We don't need to restore this activity to full extent, not even 50%. By the way, carriers of AT mutations, like parents, like many of you, have only 50% of the level of ATM. So, so the way it's done is, in principle, is very simple. We use cells from AT patients, and these cells cannot respond to, say, radiation, or we treat them with chemicals which mimic the action of radiation, simply more convenient than to use irradiation. And I guess you're all familiar with the basic technique of cell culture, and I guess many of you have donated skin biopsies or blood samples to raise cell lines. So we have cell lines from many AT patients, and we use actually just 2 of them for that. And we seed them in numerous very, very, very small cultures. Like these are actually plates about this size, each of which has 364 wells. And these wells are like square millimeter in size, that's all. And at the bottom of each well, there are a few thousands of cells, 80 cells. Now, the way we do it in wells is because this allows us to put in each of these wells, and when I say allow us to put, that's what the robot does, a different drug. So if we want to screen, for example, and we just completed a screen of 100,000 drugs, we need 300,000 wells, in each of which are the same 80 cells, but with different drug. And then we treat all of them with the DNA damaging agents, which in normal cells elicits this response that we can read. We have a lot of readouts for this response. And of course, usually in 80 cells, we don't see this response. It's really like black and white if we calibrate the conditions carefully. Now, the hope is that if any of those hundreds of thousands of drugs allows those cells to respond, we will see it. So and again, we have this high throughput screen, it's microscopic screen and so forth. And indeed, here and there, among those hundreds of thousands of wells, we do see a response, which to us means that perhaps that specific drug that we put in that specific well, in that specific plate, allowed the cells to do this. And then we take it from there. So that's the part which is done in that mega lab. Now this is the first initial screen. We have to validate it. And then we look specifically at those 5 or 6 or 10 drugs that gave this response. And those are carefully investigated in our lab in Tel Aviv. So I hope I made it clear that this is the basic idea. And like I said, this is one of the several approaches to search for a drug therapy for AT that are being used. And so we are in the midst of this process. And I think that I can simply rely on what Dr. Gatti explained to you about how costly this process is and how much time it takes and so forth. So the AT families in Israel are asking us the same question that you're probably asking yourselves. So when will all this bear fruit? And this actually takes me back to the time when we and many other groups were trying to clone the ATM gene, the AT gene. And the families at that time used to ask me, so when do you expect to, or somebody will have the gene? And I used to say to them, look, it may be tomorrow, a week from now, a month from now, or 2 years or 10 years from now. That's the way science works. And one day it did happen. So we really hope that this will happen again. But I should stress again, and this again takes me back to what Dr. Gatti explained to you, and that's true for any potential candidate drug which is found by any of these approaches. We have to make new derivatives of the drug. We have to test its toxicity first in cultured cells, then in animals, usually mice. And then, of course, do clinical trials. And it has to be approved by the authorities. And this may take time. But at least the message I wanted to bring to you is that indeed we are now finally at a stage where we think we have this basic understanding of the molecular basis of the disease, and we are ready to do what we promised we would do, that once we have this and we get this understanding, this insight, we will do our best to use them in order to identify new treatment modalities for the patients. That's basically what I want to say, and I really thank you for your attention.